is Dr. Pranita Sahay. She is the Assistant Professor, GNEC, Maulana Azad Medical College. And her topic of presentation is Amniotic Membrane Grafting, My Initial Experiences.
Good morning, everyone. At the outset, I would like to thank AIOS for this opportunity and Dr. Deepak sir for including me as a co-instructor in his instruction course. So, ma'am, thank you for the introduction. I'll be talking about amniotic membrane grafting. So, when the name of amniotic membrane graft comes, everybody thinks that this is something pertaining only to cornea specialists. But here I am to tell you that amniotic membrane grafting is a very simple procedure. If you know the basics, when, where, and how to do it, it is something that should be done by practice by everybody. Not a difficult task that you need to refer a patient to a cornea specialist for this procedure. If you know about the dealers who provide AMG in your city or state, and you know how to deal with this technique, it is something that can be done even by general ophthalmologist or ophthalmologist practicing other specialty. So basically, amniotic membrane, as we all know, consists of three layers. It has an epithelium, basement membrane, and stroma. The basement membrane contains certain growth factors which promotes the epithelialization process. It also has certain cytokines which has anti-fibrotic and anti-inflammatory effect. Now, the procurement processing is common to all the types of AMG, whether you're using a fresh, a cryopreserved, or a dry AMG. The fresh AMGs are obtained from donors undergoing cesarean section after obtaining a negative serology, that is HIV, hepatitis, HTLV, and syphilis. The placenta is cleaned under sterile conditions with BSS. The amnion is separated from chorion, and the amniotic membrane is then cut into pieces and placed on a nitrocellulose paper. Don't worry, this is not the task of an ophthalmologist. This is done in the gynae department by trained staff. But yes, obtaining a fresh AMG is something that can only be done in an institutional practice. If we are looking at private practice or small setup practice, fresh AMG is something which is not available. In such situation, you get cryopreserved AMGs or dry AMGs. So the cryopreserved AMG again comes in two forms. You can get one with a vial wherein you get AMG in the form of a sheet, or you can get Procera, which is a ring within which the AMG is embedded. Okay, so these ring form of AMGs, which are Procera AMGs, do not require any assembly. You can directly apply it like a contact lens on the patient's eye, while the cryopreserved AMG, which comes as sheets, need to be applied either with the help of a fibrin glue or with the help of vicryl sutures that we will see in the subsequent videos. Now, dry AMG comes like this in boxes. It is like a cellophane paper, and as soon as you dip it in water or normal saline, it becomes very soft and friable, just like a fresh AMG, and it retains most of the physical, biological, and morphological properties as that of a fresh AMG, except for the fact that the growth factors are limited in the dry AMG. Now, we have already seen that AMGs promote epithelialization. It has growth factors, anti-angiogenic, antimicrobial, antifibrotic factors, and it also acts like a mechanical barrier, protects the cornea from inflammatory mediators or any external agent which is constantly rubbing in the cornea. For example, cases of VKC wherein there are giant papillae. So there are various surgical techniques. You can have an inlay or a graft technique wherein you can see here that in case you have a neurotrophic ulcer or a shield ulcer, in the area where you have a corneal ulcer, you can use it as a small patch graft. You can have an overlay or a patch technique wherein you can place the entire sheet of AMG over and above your ocular surface. You can even use a combination of these two techniques wherein you can do an inlay and overlay all together. Now, it is also important to understand the orientation of AMG. Normally, the AMG comes on the nitrocellulose blotting paper. The epithelium side is up, and towards the nitrocellulose paper is the side of the stroma. So, based on the technique that you are following, you may also want to know whether you are putting it epithelium up or epithelium down. So, how to identify that? One is the nitrocellulose blotting paper orientation. The surface which is not in contact with the paper is epithelium up. The top part is epithelium up. And the other way, once you detach it from the paper, sometimes it gets messed up, it rolls up, and then you need to again identify which is the epithelium. So what you can do is just take a swab stick of a cotton or a Merocil sponge, touch the AMG. If it is sticking to the sponge, if it is getting lifted up or tented up, that means it is stroma. So what we remember is S for S, stroma is sticky, it gets stuck to your merocell sponge. Now coming to the indications, it can be used either for the conjunctival surface reconstruction or for the corneal surface reconstruction. In the conjunctival surface, which is common practice that everybody does, is pterygium surgeries. In case you have a large pterygium, pseudopterygium or a recurrent pterygium, in those cases you can obviously use AMG as a replacement in contrast to your conjunctival autograft. In addition, you may also find in your practice patients of chemical burns, SJS coming to you. In all cases of chemical burns that are grade 3, grade 4 or acute SJS with corneal involvement, if you do an immediate AMG, it is life-saving and sight-saving for these patients. Rather than wasting time and sending these patients to a cornea specialist, you can yourself do an AMG in your setup. In corneal surface procedures, wherein neurotrophic ulcers, where you have partial LSCD, you want to do a slit or a clet, in those cases also AMG is useful. Sometimes you do dermoid surgeries, lipodermoid and a mass excision or as ocular surface squamous neoplasia. In such cases, when you are creating a conjunctival defect, you want to close these areas with a graft. Conjunctival autograft is one option, but if your size is too big, AMG is a good replacement in such places, which you can easily obtain. In leaking blebs also, some glaucoma surgeons use it. So let's see a surgical video. This was a case of pseudopterygium excision with AMG. So this patient had a history of chemical injury and ended up with a pseudopterygium. Here we can see that the limbus was first marked and the pseudopterygium is being excised with the help of a crescent blade. Since the center of the cornea was not involved, I did not plan this patient for a slit and decided to go first for a simple excision of this pseudopterygium with an AMG. It is very important that once you remove such mass, you cauterize all the bleeders very well, because these bleeders tend to form a sub-AMG hematoma that can lead to infections. So cauterize all the bleeders. You can see this is the nitrocellulose blotting paper. I am removing the AMG from the blotting paper and putting it up on the corneal surface. I am putting it up epithelium down. Now here the stroma is up. There is no general consensus. Different surgeons propagate different things. You can have either epithelium up or down. And once you cut it and place it on the surface, you can just apply a few drops of fibrin glue and spread it up gently to cover the entire area of epithelial defect. You can even keep it a millimeter beyond it. With fibrin glue, it is always important that whatever is the residual or extra glue needs to be cut or trimmed, or else it causes irritation, and sometimes that can be a foreign body because of which the patient rubs and blinks too much, and it can cause dislodgement of your AMG as well. So cut whatever is the extra AMG or extra glue. Next, this was a case of a chemical injury, a young lady who presented with toilet cleaner acid injury. And she, as you can see in the picture, the top is the baseline picture, that the cornea, although is looking clear, on fluorescent stain you can see there's a nearly 90% epithelial defect and 9 cloaca of limbus is involved. The conjunctiva is showing blanched out vessels. It is a grade 5, Dua's grade 5 chemical injury. In such case, if you do an immediate AMG and placement of a symblepharon ring and maybe a temporary tarsorrhaphy for some time, you can have, gratifying results. You can see day 14, the AMG starts to disintegrate. Day 21, again, it is becoming, starting to disintegrate. And by 3 to 4 weeks, the AMG completely dissolves and it has served the purpose, given you the growth factors, given the mechanical barrier, and helped the epithelialization process without any signs of limbal stem cell deficiency, which is a likely outcome if you don't treat chemical injuries in time. Now this is another patient, a kid who presented with shield ulcer, and it was recalcitrant to medical therapy. So we decided to take the child in GA for shield ulcer debridement with AMG application. So here with the crescent, the AMG, the shield ulcer plaque is being debrided. These are very thick, needs to be sometimes peeled or removed with the help of crescent. And on the top of it, AMG again is being put with the epithelium side down. Now, in case if your ulcer is too deep and you think that the cornea is thinned out, you can even do a multi-layered AMG in this case. That is, you put a small patch in the site of the ulcer, and over and above that you put a full layer of AMG covering the entire ocular surface, which will protect it from the giant papillae rubbing onto the corneal surface and also help in the epithelialization. Now in this case we did not use a glue because the patient was not affording. We had used the Vicryl sutures, which can be very well used. Now, it is very important when you're doing a vicryl suture in AMG that you take big bites, big bold bites. You need to hold the tenon and conjunctiva well, because what happens is if you take a small bite, the AMG is very thin and friable. It will either cut through cheese wire and cause dislodgement or displacement of the AMG in the early post-op period. So take a big bulk, both of the AMG, conjunctiva, and try and take the tenons also. And at least it should be 1 to 2 millimeter wide, multiple interrupted sutures, and avoid large conjunctival vessels, because if you hit any major vessel, it will lead to a large subcon hemorrhage and sub-AMG bleed, which is very difficult to remove once your graft is in place. This was a case of a 10-year-old child who presented late with a chemical injury sequelae, wherein AMG was used for slit. Again, another patient, she presented with this mass lesion in the left eye temporal aspect, suspected to be a lipodermoid, and we removed the lipodermoid. It was extensive and it was quite adherent to the conjunctiva. Despite of the best attempts to preserve the conjunctiva, we ended up in having a large conjunctival defect, and hence we closed it with the amniotic membrane graft. Large defect, if you try and just close, trying to oppose the conjunctiva, you can have shortening of the fornix and limitation of extraocular movements as well. So try and use, replacement for a conjunctival defect, which can be either an autograft or an AMG. Now this was a case of OSSN, wherein you have to do a large margin clearance. Obviously you end up having a large defect. Again, AMG was used for clearing it, for closing this defect. Post-operative management, you just need a topical antibiotic for 2 to 3 weeks and a topical steroid for 6 to 8 weeks, because in 4 to 6 weeks time your AMG completely dissolves, so you don't need steroids. Over and above that, lubricant obviously you can give for comfort, and over and above that, based on the indication that you're treating, you give on add-on medications. The complications that you can have is displacement and dislodgement of the AMG is one of the most common complication. At day 3 or day 4, the patient comes to you, almost 50% of the AMG is coming out of the lid. So just proper suturing and proper placement is something which is essential. And in case the AMG is getting dislodged and you think it's a recent dislodgement, you can even attempt a resuturing of the displaced AMG.
I would request you to please wind up.
Okay. So, and other complications are hematoma and microbial infections. So the take-home message is there are various clinical applications, but it's a simple surgical technique with low intraoperative and postoperative complication, and hence you can definitely use in your routine practice. Thank you.
Thank you, Dr. Pranita. That was a wonderful presentation.